Surface electromyography response of muscles of mastications in normal individuals and in bruxers, and the impact of occlusal splint. So I'm the chief dental surgeon of A1 Zion Dental Clinic located in Chennai, India, and also the Faculty of Allied Health Sciences. I have also completed my master's in neuroscience after dental surgery and the 2 fellowships, one in cosmetology and trichology. So on introduction, we know that the masticatory muscles perform functional and parafunctional habits. So the functional activities are chewing and speaking, and the parafunctional activities are clenching and grinding of the teeth. When non-functional contact occurs due to rhythmic masticatory muscle activity between the teeth, it leads to occlusal wear and orofacial pain. And such a non-functional contact is called as bruxism. So the term bruxism originated from the Greek word brychein, meaning to grind or gnash the teeth. And bruxism is of major concern to the dentist as its severity results in damage to the teeth and restorations, tension type headaches, facial or jaw pain, and temporomandibular joints. So we know that the majority of muscles involved in bruxism are masseter and temporalis because they help in elevation and clenching of the muscles. And we can see the effects of bruxism on the teeth. So being a dental surgeon in my undergraduate, I was able to see this, and this was my thesis in my PG neuroscience course. So we can see the very hazardous effects of bruxism or the night grinding or gnashing of teeth. And we can see like the enamel, we have 3 layers of teeth outside. I mean, the crown layer has got enamel, dentine, and coronal pulp. So here we can see like the teeth are having attrition or wearing of the enamel and the dentine surfaces. And we can also see in the lower jaw that the teeth are even exposing the pulp. So such a so bruxism has got such a hazardous effect on our teeth, which results in hypersensitivity, masticatory difficulties, and occlusion or your bite difficulties. So the most frequent symptoms or causes of bruxism result in head pain or headache. They cause discomfort around the eyes, pain behind the eyes, bloodshot eyes, and around your mouth you can get discomfort. You can get limited opening of mouth, which we call it as trismus. We can also have an inability to open your mouth smoothly, and you also can develop lockjaw because of temporomandibular joint disorder as a result of bruxism. And your teeth can also the normal occlusion and the masticatory load may be distributed unevenly, and the patient can also go in for ear problems, and they can have vertigo, tinnitus or ringing in the ears, dizziness, jaw problems, neck problems, and also with swallowing difficulties such as dysphagia and laryngitis, sore throat, etc. So when we have to assess a patient, so we have to see there is a parafunctional habit. So we have to see the risk assessment by checking around the headache, the neck, and the jaw problems, whether the patient is going in for clicking, grating, neck pain, uncomfortable jaw, headache, and orofacial pain. So this is a list of the signs of bruxism to sum it up. So the patient can do a grinding or a clenching of the teeth, often loud enough to wake a sleeping partner. We know that bruxism is generally classified as nocturnal or diurnal, flattened, chipped, loose or fractured teeth, worn out tooth enamel, sensitive teeth, pain or soreness in your jaw or face, and jaw muscles that are too tired or tight, pain in your ear like an earache, even though there's nothing wrong with your ear, because you've been grinding, the patient has been grinding the teeth all night long or all day long in diurnal bruxism or nocturnal bruxism. So the patient has been grinding the teeth continuously. So the patient will always have a discomfort in the ear because we have our temporomandibular joint located internal to the ear. So, and we have headache starting in our temples and cheek damage because the patient can chew on the inside of the cheek. That is, the patient can insert the buccal mucosa by mistake between the upper and the lower teeth, and then the patient can have tongue indentations and a lockjaw. So these are all the signs of bruxism from which the patient can suffer. So now we have found out a tool called surface electromyography. We know like surface electromyography is to measure the electrical activity of the muscles by placing surface electrodes, and it's a non-invasive procedure. Now we are going to see the role of surface electromyography in bruxism and how it is helpful in detecting the muscle activity. It is a comparative study between normal individuals and bruxers. So unlike needle EMG, surface EMG electrodes typically around 10 mm in diameter, and usually they are passive. So they are simple conductive surfaces with requiring low electric resistance. And surface EMG can record both voluntary and involuntary motor activity. And as a result of recording the surface EMG, we get motor evoked potentials, motor unit action potentials, MUP trains we are called. And in that, we are going to see the highest amplitude of each activity. So the aim and objective of my study was to record and compare the masticatory surface EMG of masseter and temporalis muscles in healthy individuals and in bruxers. And after recording the surface EMG, what I did was I gave a occlusal splint. I took an alginate impression of the upper and the lower teeth, and I gave the occlusal splint to the patient, recalled each bruxer after 8 weeks, and re-recorded the surface EMG response. So materials and methods, and the study was conducted in only around 20 subjects, of which there were 10 asymptomatic volunteers, which formed the control group, and 10 bruxers with habitual grinding of teeth at night. So the bruxers were screened based on their clinical history from the patient's family and the bed partner, and the oral examination was performed for each patient based on the diagnosis. So the inclusion criteria of my study, of my original research work, patients with a self-reported history of frequent tooth grinding as confirmed by the sleep partner. Presence of tooth wear on the occlusal surface. Jaw muscle pain may be present in some patients. Exclusion criteria, patients with neurological disorders like stroke, dementia, seizures were excluded because they could not cooperate in the study. And subjects with malocclusion, subjects with fewer than 2 posterior teeth in one quadrant, because there will be a missing teeth and we cannot record the surface EMG properly, and subjects with craniofacial disorders. So electromyography activity, it was recorded bilaterally from masseter and temporalis using surface electrodes which are disc in type. So they were placed along the direction of the muscle fibers. The reference electrode is pleasant. So the active electrode was placed along the direction of the muscle fiber. It's used using the belly and tendon technique. So the most contractile part of the muscle, we placed the active, and the reference electrode was placed 3 centimeter distal to it, and here I placed it on the mastoid process, and we have to have a ground that was placed on the forearm. The procedure was explained to the subjects and the activities that needed to be performed. So the physical activity that I selected was, we had an oral task collector software, and the patients were asked to perform coughing, deep breathing, canine grinding, tooth tapping, etc. So the skin, so we need to prepare the skin, and the skin was vigorously rubbed and cleaned with an alcohol swab to reduce the surface impedance, and then the electrodes were filled with conductive paste and secured with self-seating adhesive disc. So the electrodes were connected to a 2-channel programmable electrophysiologic system. So this is an example of my subject, which was performed in an EMG lab. And these were the signals that were obtained. So we can see the MUP trains, motor unit potential trains, that are obtained during each physical activity. So you can see in this slide, you can see the activities which are lined. So one is canine grinding. So I asked the patient to bring the upper and the lower canines, maxillary and mandibular canines in contact, and they were grinding the teeth. So during that time, I recorded the surface EMG, and a similar activity was recorded. And then jaw protrusion. So when the patient is protruding the jaw, we recorded the surface EMG. And then lip biting. So during each activity, the amplitude. So the amplitude of each, the highest MUPs that were obtained were recorded. And coughing and deep breathing. So these 5 activities were given to each of the bruxers and each of the normal individuals as the control group. And the amplitude of the highest peak in a cycle was recorded for analysis. The patients were asked not to take any muscle relaxants or sedatives prior to the test because it could affect the amplitude. And impression making. So once the electromyography was recorded, the patient's impression was taken with alginate and the models were poured with dental stone. So these are the models. And using the models, there was so the right side picture shows a splint. So the left side model, the first picture shows a model with the patient's teeth, and the occlusal splints were fabricated in a lab, and it was fitted on the patient, and the patients were instructed to wear it completely during sleep, especially during sleep, and they were asked to wear it repeatedly except during having their food and water for 8 weeks continuously, maintain good oral hygiene, and they were asked to come for re-recording of the electromyography for a comparison of the power of the masseter and temporalis muscles. So again, the amplitudes were recorded, giving the patient the same exercises. So results, the surface EMG. So comparing the surface EMG of the masseter and temporalis of the controls and the bruxers, we found, we calculated the mean, standard deviation of the raw score of the amplitudes of the EMG signals. We analyzed the same by standard error method to obtain the significance of each activity by calculating the p-value, and comparing to the surface EMG of the masseter and temporals of the controls, we found that the bruxers had high amplitudes. And after the splint was given and the patients were instructed to wear it for 8 weeks continuously, there was a significant reduction in the amplitude values of the bruxers, and this was how we evaluated the efficiency of the soft splint. So these are the amplitude values of the surface EMG that we obtained in the controls. So I have divided according to the age, and the last of the tabular column shows you the sum, mean, standard deviation, mean plus standard deviation, and the activities are as follows. So these are the amplitude values of the surface EMG in bruxers. So during splint and post splint, before splint and post splint, the amplitude values of the surface EMG. Statistical significance, we found that the mean and standard deviation were calculated, and the p-value was found to be extremely significant and very significant. And less than 1 or 2 activities, the p-value was not found to be very significant. So impact of occlusal splint. Finally, we found that the impact of occlusal splint, it had a positive impact, because the patients, when they used the splints for 8 weeks, the mean and the standard deviation of the amplitudes were found to be significantly reduced, and that thereby the p-value was assessed and found to be extremely and very statistically significant. So conclusion, so by this study, we can use our occlusal splint in dentistry, and also have a patient come again for the surface electromyography response to find out that the hyperactivity of the muscles, masseter and temporalis, are controlled. We can also save the patient from hazardous effects on the enamel and dentin of the teeth. So I thank one and all for this wonderful opportunity to share my views on my research project. Thank you.
Thank you, Dr. Aida. It was an excellent presentation, and I hope all the participants have learned and been benefited by your research work. If
Thank
any
you,
of the
ma'am.